Hello and welcome back everyone. So continuing our discussion about the pediatric emergency medicine, in this video we will talk about the bronchiolitis. So bronchiolitis is inflammation of the small airways inside the lungs known as the bronchioles. So such as you can see in this picture here, it is inflammation of the small airways running inside the lungs, and this occurs in infants and very young children younger than 2 years of age, and this will lead to fever, cough, rhinorrhea, and wheezing, and severe cases will develop respiratory distress. And there is no agreed on diagnostic criteria for this illness, and it can be easily misdiagnosed as pneumonia or asthma. And this disease is mild and self-limited in most cases. Now, bronchiolitis is mostly caused by viruses, so it is viral illness, and respiratory syncytial virus, RSV, is responsible for more than 50% of bronchiolitis cases. And other viruses include human metapneumovirus, rhinovirus, parainfluenza virus, influenza virus, Boca virus, and adenovirus. And bronchiolitis is rarely followed by a bacterial superinfection. Now, there is some risk factors linked to bronchiolitis. So there is high risk of developing bronchiolitis in preterm infants and in infants with low birth weight and when their age is less than 5 months, and also occur in low socioeconomic status families, and also in infants with airway anomalies and chronic lung diseases, and also in immune deficiency disorder cases, and when there is parental smoking. Now let's talk about the pathophysiology. So infection causes inflammation of the small airways, the bronchioles, leading to edema, small airway epithelial cell necrosis, and sloughing, and increased mucus production and mucus plugs, and bronchospasm. So as you can see in this picture here, we have inflammation of the small airways inside the lungs, leading to increased mucus production and edema of the airway, and small airway epithelial cell necrosis and sloughing, which will accumulate and block the airway. Now, all of these factors increase resistance in the small airways, and this means that the resistance will be increased during both inspiration and expiration, but because the radius of the airway is smaller during expiration, this results in wheezing. So the infant and the very young child will develop wheezing, and also air trapping and lung hyperinflation develop. That is because the radius of the small airway is decreased during expiration, and since the airway is already narrowed with the mucus produced and the epithelial cells and the debris coming from the epithelial cells sloughing and necrosis, this will lead to blocking of the airway during expiration, but then the airway return to being open during inspiration. And this means that the airway would act as a one-way valve, leading to air trapping and lung hyperinflation. But then, if the airway is obstructed fully during inspiration and expiration, the trapped air will be absorbed and the child will develop atelectasis. Now, hypoxemia is a consequence of ventilation-perfusion mismatch. Since we have good perfusion to all the lung, unfortunately we don't have good ventilation to all of the lung. We have some areas that the air doesn't reach. And with severe obstructive disease, hypercapnia can develop. So we can either have a type 1 respiratory failure or type 2 respiratory failure. Now let's talk about the epidemiology. So over 100,000 young children are hospitalized annually in the United States with the diagnosis of bronchiolitis, making it the most common diagnosis, resulting in hospitalization for children younger than 1 year. So it is very common. Now, bronchiolitis is more common in males and those exposed to secondhand tobacco smoke, as we mentioned in the risk factors, and those who have not been breastfed, and those living in crowded conditions. And risk is also higher for infants with mothers who smoked during pregnancy. And older family members, including older siblings, are a common source of infection, and they might experience only minor upper respiratory symptoms. That is because their bronchial edema may be less clinically apparent because they have bigger airway size. Now let's talk about the clinical features. So infant with bronchiolitis first develop signs of upper respiratory tract infection with sneezing and clear rhinorrhea, and may be accompanied by decreased appetite and fever, and gradually respiratory distress occur with paroxysmal cough, dyspnea, and irritability, and the infant is often tachypneic, which can interfere with feeding. Now, respiratory distress manifests as increased work of breathing with nasal flaring and subcostal and intercostal restrictions, and there is also increased respiratory rate, and wheezing and crackles usually present, and expiratory time may be prolonged, and complete obstruction to airflow can eliminate the turbulence that causes wheezing. Thus, the lack of audible wheezing is not reassuring if the infant shows other signs of respiratory distress. So poorly audible breath sounds suggest severe disease with nearly complete bronchial obstruction. Also, the infant may develop apneic event, that is when respiratory arrest occur for 20 seconds or more, and this may precede the lower respiratory signs early in the disease, particularly with very young infants and term infants at a post-conceptual age of less than 44 weeks, and preterm infants at a post-conceptual age of less than 48 weeks are at highest risk for apneic events. And dehydration can also occur due to poor feeding and tachypnea, and hypoxemia, cyanosis, altered mental status are signs of severe disease. Now let's talk about the diagnosis. So diagnosis is clinical and does not require laboratory or radiologic studies. The patient with the bronchiolitis are less than 2 years old, and peak presentation is 6 to 12 months of age, and they have an upper respiratory tract infection which manifests as cough and rhinorrhea, and also wheezing, and they don't have history or family history of wheezing or atopic diseases, and they present during a respiratory syncytial virus or other respiratory viral pathogen outbreak. Now, radiologic studies in form of chest x-rays may show areas of atelectasis in bronchiolitis and may be difficult to distinguish from bacterial pneumonia, so it is quite confusing. And as a result, obtaining chest radiography in a patient whose clinical course and examination are consistent with bronchiolitis may encourage unnecessary antibiotic use. So as you can see in this picture here, this is a chest x-ray of a baby with bronchiolitis, and you can see that we have right upper lobe atelectasis here, and also we have left lower lobe atelectasis. Additionally, we have lung hyperinflation and flattened diaphragms, and this is quite difficult to distinguish from pneumonia. So obtaining an X-ray and seeing these signs may encourage unnecessary antibiotic use in a disease that is caused by a virus. Now, laboratory testing is also not routinely indicated. The white blood cell and differential counts are usually normal, and are not predictive of bacterial superinfection. Now, viral testing in form of PCR or rapid immunofluorescence is not routinely recommended also in the diagnosis of bronchiolitis, but may be helpful if such testing prevent more invasive evaluations. Now, concurrent serious bacterial infections such as sepsis, pneumonia, and meningitis are unlikely with the bronchiolitis, and confirmation of viral bronchiolitis may prevent the need for sepsis evaluation in the young febrile infant. Now, for young children with wheezing in whom the presentation does not clinically fit with the diagnosis of bronchiolitis, including those without other signs of viral infection and those with very severe presentation or complicated clinical course, further workup should be considered in form of radiology and laboratory testing. Now, children with recurrent or refractory episodes of wheezing in infancy, particularly if associated with failure to thrive, may require evaluation for chronic disorders such as cystic fibrosis or immunodeficiency. Now, otitis media is a common complication of bronchiolitis. Now let's talk about the differential diagnosis. So we have asthma and pneumonia. Regarding asthma, bronchiolitis and asthma both have wheezing as its most prominent clinical sign, and most infants with bronchiolitis are unresponsive to both beta agonists and corticosteroids, while infants with asthma have a very good response to these medications, so you can use them to differentiate. And regarding pneumonia, pneumonia can have all of the bronchiolitis symptoms, but it comes with laboratory findings such as leukocytosis. Now let's talk about the treatment. So treatment in these children with bronchiolitis is supportive. So those who are experiencing respiratory distress in form of hypoxia, inability to feed, apnea, extreme tachypnea should be hospitalized, and risk factors for severe disease include younger age, preterm birth, underlying comorbidity such as cardiovascular, pulmonary, neurologic, or immunologic diseases. Now, hypoxemic children with SpO2 less than 90% should receive supplemental oxygen, and oxygen can be administered via nasal cannula or high-flow nasal cannula in moderate to severe cases, or via positive pressure ventilation, CPAP, in severe cases. And of course, intubation and mechanical ventilation is the last resort if all of these did not work. Now, hydration should also be given to children with severe disease. Fluids can be administered intravenously or enterally via nasogastric tube. Now, NG feeding is preferred, and it is indicated when the respiratory rate is higher than 60 breaths per minute to prevent aspiration, because direct enteral feeding with those infants with respiratory rate higher than 60 may lead to aspiration and pneumonia. So we have to give them feeding via NG tube to prevent that. Now, frequent suctioning of nasal and oral secretions often provides relief of distress and improves work of breathing and ability to feed, although this should be limited to the nares or the oropharynx, because deep tracheal suctioning does not provide additional benefits. Now, chest physiotherapy provides no benefit to children with bronchiolitis. Now, albuterol and corticosteroids are proven ineffective in bronchiolitis, and neither are currently recommended for management. They have no role in management of bronchiolitis, but you have to trial them first to make sure that the patient doesn't have asthma. Now, nebulized hypertonic saline decreases mucus production and is still used in bronchiolitis, although most studies fail to demonstrate it being beneficial. Also, nasal vasoconstrictors are not indicated and have resulted in tachydysrhythmias. Now, racemic epinephrine has not been found to improve length of stay or clinical outcomes among inpatients with bronchiolitis, but there is some evidence suggesting it reducing hospitalization rate with infants if used outpatient. Ribavirin is the only currently available antiviral medication targeting the respiratory syncytial virus, is also not currently recommended because minimal impact on disease outcomes and because it is costly and difficult to administer and associated with multiple toxicities. It may lead to hemolysis, hepatotoxicity, and allergic reactions. Now let's talk about the prognosis. So infants with acute bronchiolitis are at highest risk for further respiratory compromise in the first 72 hours after onset of cough and dyspnea. So severity increases over the first 3 to 5 days, with total duration of illness is 7 to 14 days. So in severe disease, disposition is done when the patient is well after the 5-day mark. Now mortality rate is less than 1% in developed countries, with death attributable to respiratory arrest and failure or severe dehydration and electrolyte disturbances, and majority of deaths due to bronchiolitis occur in children with complex medical conditions or comorbidities such as bronchopulmonary dysplasia, congenital heart diseases, or immunodeficiency. Finally, let's talk about prevention. So meticulous hand hygiene while dealing with these children is the best measure to prevent transmission of the viruses responsible for bronchiolitis to other children, and balavizumab is an intramuscular monoclonal antibody to the RSV F protein, may be given as a prophylactic agent. Balavizumab has been demonstrated to reduce risk of hospitalization due to RSV bronchiolitis. Now balavizumab is indicated in children born at less than 29 weeks of gestation, and also in children with significant heart diseases or chronic lung disease of prematurity, and it may be considered in infants with neuromuscular diseases and immunocompromised states. And with that, we reach the end of this video. Thank you guys for watching. Please give us a like, comment your ideas and questions, and subscribe. And please consider joining the channel by hitting the join button near the subscribe button down, or by following the link in the description of this video. Thank you for watching, and peace.